Good morning. My apologies for not being able to be with you this morning due to a family emergency. It is my pleasure to present Health Disparities, the Impact of Social Determinants of Health. I would like to take a moment to disclose the following: AAE President, an HLBI Coordinating Committee member, AstraZeneca Primary Care Advisory Board, PT027 educator, Teva Respiratory National Advisory Board, WNC Lighthouse Board of Directors, WNC Bridge Foundation, Asthma Rural Health Consultant, Asthma Alliance of North Carolina Board Member, Education Chair, University of North Carolina Stakeholder Advisory Board Member, Journal of Asthma Peer Reviewer. Additionally, I would like to disclose that I have no conflicts of interest. The objectives include: the participant will be able to describe health disparities, and the participant will be able to identify social determinants of health. The World Health Organization estimates that 262 million people worldwide have a diagnosis of asthma. Asthma is one of the United States' most common and costly diseases, affecting 25 million Americans. The disease is becoming more prevalent among minorities and low-income populations. Asthma in these populations is associated with higher risk of lower school performance, fragile nutritional status, and inadequate housing. Uncontrolled asthma can lead to airway remodeling, asthma exacerbation, and death. In the last 12 months, approximately 10.3 million people have experienced an asthma exacerbation. Children are at particular risk, as asthma is the most common chronic disease for children, and the third most common reason our children are hospitalized. 1.8 million ED visits are attributed to asthma, 169,000 hospitalizations with a primary diagnosis of asthma. The CDC reports each day in the United States, approximately 10 people die from asthma-related deaths. The annual national asthma mortality is 4,145 lives. The national impact of asthma exceeds $81.9 billion per year, including medical expenses and loss of productivity resulting from missed work days and school. I would like to take a moment to share with you the story of Jenny, a 7-year-old little girl that was referred from the peds pulmonologist due to hospitalizations and ED utilization. Social services was also involved with this child and family due to the number of missed school days. When we arrived at their home, we found that 3 families were living in the home, one due to loss of a job and one family loss of a spouse. The asthmatics family lived primarily in the living room area and had all of their belongings confined to that area. The family slept on the bedding that you see here and on the furniture. There was no bed linen, there was no pillows. There was a huge hole in the center of the mattress where the family slept. The furniture was threadbare and was one of the worst sights that I had seen in my years of doing home visits with asthmatics family. Additionally, there was pest infestations, visible signs of roaches on the walls, roaches climbing throughout the living room, the kitchen, and throughout the home. Additionally, there was plumbing concerns. The sewage was seeping up through the bathtub. There was holes in the flooring. We could see the dirt foundation. Additionally, there was electrical concerns. Waste Pro donated a dumpster that they provided in kind, which we had to have it dumped 2 times due to the number of content that was in the home. We worked in partnership with churches and community partners to address social determinants of health and implement solutions. After several days of work, this was a finished product. The furniture that you see here was donated by 501c3. The couch turned down into a sleeper sofa, allowing the family to sleep on that. Additionally, the church provided and remodeled the bathroom, including replacing the subflooring. Also, a plumber addressed the plumbing concerns, as well as an electrician rewired many parts of the home. We found out that the family was living with the grandparents or with their mom and dad, and had utilized the monies, what little money they had, to replace the roof due to multiple roof leaks. We have gone back since that time and visited this family on several occasions. The home continues to be very clean and free of pests. They're very proud of their home. We have noted a significant improvement in the little girl's health status and an improvement in her attendance at school. Additionally, the overall health status of many of the family members has significantly improved. The mother, who suffered from depression, diabetes, has had a significant improvement in her overall health status related to chronic disease states. And she had made the comment that what turned into a health partnership became a friendship. Health disparities may be defined as an attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Healthcare disparities exist in the general population of developed and underdeveloped countries. Groups are commonly delineated by gender, age, income, race, educational background, geography, and disability. The health of individuals is influenced by social and economic factors, often referred to as social determinants of health. The World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. The 5 classifications of social determinants of health include economic stability, education, social and community context, health and health care, neighborhood and built environment. Food insecurity, housing instability, lack of transportation, and interpersonal violence are all examples of social determinants of health. According to the Centers for Disease Control and Prevention, social and economic factors contribute up to 75% of population health, and approximately 50% is attributed to health outcomes. Surprisingly, medical care contributes 10 to 15% to population health. The purpose of the study, a scoping review of social determinants of health in children with asthma, was to examine how social determinants of health affect asthmatic children living in rural communities in the southeastern United States. Cumulatively, 877 peer-reviewed articles were screened. Studies considered for review had as their focus children with a diagnosis of asthma living in the rural southeastern U.S. with a reference to at least one social determinant of health. In total, 516 articles were deemed relevant for the asthmatic child ages 0 to 18 residing in the southeastern United States. Based on the inclusion and exclusion criteria, 15 articles were chosen for the scoping review. Social determinants of health are noted root causes of medical problems, poverty being the greatest threat to a child's overall well-being. Approximately 41% of the United States children live in low-income families. According to the CDC, in the United States, the burden of asthma falls disproportionately on poor children. The majority of poor children live in the South. Health disparities are well documented to be associated with poverty and other social determinants of health, including home insecurities, food instability, lack of transportation, and access to health care. Adverse childhood experiences include physical, sexual, or emotional abuse, or a dysfunctional home, such as substance abuse in the home. ACEs have a lifelong impact on the health of our children. ACEs are associated with chronic disease, premature death, risky health behaviors, and poor achievement. Approximately 50% of children in the United States have experienced at least one ACE. Economic hardship, meaning hard to cover the basics of food and or housing, and parental separation or divorce are the most common ACEs. The research identified a relationship between childhood poverty, exposure to ACEs, and the diagnosis of asthma. Poor children are exposed to toxic stress, lack maternal support, a nurturing environment, live in lower quality neighborhoods with exposure to polluted air and water, and have a higher incidence of chronic disease. The study recognized the importance of addressing social determinants of health as part of the child's quality of life and should be part of the healthcare delivery system. The USDA estimated that 1 in 6 children reside in homes where food is insecure at some time during the year. The study found that food insecurity is associated with a higher likelihood of chronic conditions among children. The evidence was supportive of negative health consequences such as stomach aches, frequent headaches, and colds associated with lack of food. In addition, higher utilization of the healthcare system, specifically hospitalizations, was associated with food insecurities among children. The U.S. Department of Housing and Urban Development estimated that 33% of people who sought shelter were families with children, and approximately half of those children were ages 5 or younger. Many families with low income spend more than 50% of their income on housing. Unsafe and unstable housing for children and families is associated with poor health status and increased healthcare utilization. Transportation barriers are common among the underserved population. Lack of transportation is often cited as a barrier to healthcare access. Transportation limitations often lead to missed appointments, delayed care, missed medications, resulting in the poor management of chronic health conditions. Hughes and others reviewed 25 studies and found that 10 to 51% of patients listed transportation as a barrier to accessing the healthcare system. In 2009, the Regional Asthma Disease Management Program was one of 13 national asthma demonstration sites designated by the National Heart, Lung, and Blood Institute of the National Institute of Health. We participated in the National Asthma Control Initiative demonstration project. Our study was published in the Journal of Asthma in August of 2015. 50 children were enrolled in the study between 2009 and 2011. The charts were audited to assess several different indicators of program effectiveness and found statistically significant improvement across all variables. The mean age of the sample population was 8 years. The age range was 3 years of age to 12. The male to female ratio, respectively, was 56 to 44%. Ethnicity included 38% Caucasian, 28% American Indian, 6% Hispanic, 4% American Mexican, and 24% African American. The results were generated by Mission Health System Research Institute by parametric and non-parametric tests utilizing the SAS model. P was less than 0.05. ED visits decreased from 158 prior to intervention to 9 24 months post-intervention for a cost savings of approximately $142,000. Hospitalizations decreased from 60 prior to intervention to 3 24 months post-intervention for a cost savings of approximately $687,000. Quality of life was measured by school absences. The average number of days missed per child prior to intervention was 17 days. Post-intervention was 9 days per child. Clinical variables also indicated a statistically significant improvement in lung spirometry. Average percent improvement for FVC was 7.2%. FEV1 was 13.1%. FEF 2575 was 21.1%, inclusive of all subjects. They may have had SABA on board, oral steroids, or air trapping was evident. Additionally, fractional exhaled nitric oxide improved by 3.4 parts per billion. Local churches, youth groups, and charitable community partners were utilized to provide home remediation and other services to our underserved population throughout the western region of North Carolina. Approximately $66,000 was provided in kind over a 2-year period. In 2012, the Regional Asthma Disease Management Program of Mission Health System was one of 4 sites to receive a United States Environmental Protection Agency asthma grant. 61 children were staggered enrolled in this study between 2012 and 2014. The charts were audited to assess several different indicators of program effectiveness and found statistically significant improvement across all variables. The mean age of the sample population was 8.4. The age range was 1 to 17 years of age. The male to female ratio, respectively, was 57 to 43%. Ethnicity, 23% were American Indian, 54% Caucasian, 10% African American, 8% Hispanic, and 5% Hispanic American Indian. The majority of children were Medicaid beneficiaries. Level of severity at baseline, 2% intermittent, 16% were mild persistent, 69% moderate persistent, 13% severe persistent. Level of control at baseline, 5% were controlled, 34% were not well controlled, and 61% were very poorly controlled. The results were generated by Mission Health System Research Institute by parametric and non-parametric tests utilizing the SAS model. Again, P was less than 0.05 by non-parametric, and P is less than 0.01 by parametric. ED visits decreased from 102 prior to intervention to 8 following intervention for a cost savings of approximately $99,000. Hospitalizations decreased from 56 prior to intervention to 7 following intervention for a cost savings of approximately $646,000. Quality of life was measured by school absences and the asthma control test. Average number of days missed per child prior to intervention was 13.1 days, which decreased to 3.7 days per child following intervention. The asthma control test act at time of enrollment was 15.7, which improved to a score of 22.7. Clinical variables also indicated a statistically significant improvement in lung spirometry. Average percent improvement for FVC was 9.6%. FEV1, 9%. FEF 2575 was 7.6%, and fractional exhale nitric oxide was 3.2 parts per billion. Again, lung spirometry was inclusive of all 60 subjects. They may have had SABA on board, oral steroids, or air trapping was evident. 61 environmental assessments were completed in the homes of our asthmatic children enrolled in the study. We utilized an 8-page questionnaire in partnership with the National Center for Healthy Housing and the U.S. EPA. The average number in household was 5. Approximately 46% had one or more smokers in the home. 61% had one or more pets in the home. Pest infestation inside the home was greater than 50%. The majority of homes had carpet in the homes, which is a concern related to dust mite allergen, which is the #1 trigger for asthmatic children. Approximately 40% of the homes had a water leak inside or outside the home, and fungal growth was noted inside the home of about 41%. The majority of homes had a vented heat source. 16% had an unvented heat source. Oftentimes it was the kerosene heaters that sits typically in the living room. They're unvented, and so carbon monoxide was another potential contaminant that triggered an asthmatic child's asthma symptoms as well. Air conditioning, approximately half had a centralized air conditioning unit. 30% had a window unit, and approximately 18% did not have an air conditioner. Sometimes when we went into the homes, particularly during the summer times, the temperature inside the homes could be well around 80, 85 degrees in those homes that did not have an air conditioner. Additionally, bedding encasement. We provided bedding encasement to all of our asthmatic children enrolled in the study. We utilized local churches, youth groups, and charitable community partners to address social determinants of health, providing bedding encasements, pest control services. One family received an HVAC system in sponsorship with a local DSS department. $3,000 were provided in kind, flooring and windows, doors for home remediation, plumbing, bathroom replacements, roof repairs, furniture, the bed, sofa. Often one of our charitable community partners provided those, and one of the local hotels provided furniture to many of our underserved families. Approximately $12,000 was provided in kind by Hearts with Hands, MANA, Upward Ministries. Heating assistance was provided in kind as well to several families, as was emergency assistance, often addressing the electrical bills that families were unable to pay for their electricity, and many times it was going to be cut off the next day. Additionally, we provided Christmas for several different families. Car seats were provided by one of our vendors as well, as was clothing for a total of $66,000 were provided in kind over a 2-year time period. There is a great need for creative solutions that mitigate the effects of childhood poverty. Ongoing research is needed to determine the best approach to address the needs of our children living in poverty and other social determinants of health. Asthma is a complex disease. However, evidence is clear that socioeconomic variables are clearly important in the epidemiology of the disease process. Social determinants of health can significantly impact an individual's well-being and increase healthcare utilization. An innovative integration of medical care for the family and child, home, and community is necessary to eradicate the disparities in asthma outcomes and other chronic disease states. To close the gap, disadvantaged populations need better access to care. Integrated services must work to overcome social determinants of health, such as homelessness, food insecurity, and substance use. And providers who serve disadvantaged populations need education and support to adhere to evidence-based guidelines. The evidence-based for the interventions to improve asthma outcomes is strong. However, far less is known about how to transform the healthcare system into one that holistically addresses medical and social needs. Without integration, current medical efforts will fail to meet the complex needs of our most vulnerable populations. Thank you. Again, thank you. I have joined you live to answer any questions that you may have.